in the next 15-20 minutes, I'll be talking to you about distal humeral fractures. We will be covering during the next 15 minutes supracondylar fractures, fractures of the lateral humeral condyle, and medial epicondylar fractures. The learning outcomes of this lecture is to define the fractures, their classifications, the methods of treatment, indications for fixation, and complications. When we talk about supracondylar fractures, you must all be aware of the Gartland classification, which classifies these fractures into 3 types. With a fracture like this being a Gartland type 1, a Gartland type 2, and a Gartland type 3. The AO have subdivided these fractures into 4 types, where when you start talking, you see whether it's a complete fracture or not. Is there any bony continuity? If there's no bony continuity, this brings you down to the unstable complete fractures. If there's bony continuity, you go up to here, and when you look at the lateral view, you are all aware of what's called the anterior humeral line, or the Rogers line. This line should intersect the lateral humeral condyle of the capitellum. If this intersects the humeral condyle, this anterior humeral line, in a fracture like this is considered a type 1, where the anterior humeral line intersects the capitellum, and in the AP view there is less than 2 millimeters of varus of valgus angulation. If this does not intersect the capitellum, the anterior humeral line, like in this fracture, or there's a varus valgus malalignment of more than 2 millimeters, this makes it a type 2. When there's no bony continuity at all, if still there is contact between the fracture planes, like in these fractures, this is a type 3. If there's complete loss of continuity, if these fragments together, there's no contact at all, this is a type 4. The concerns in these fractures are the ability to achieve closed reduction and to maintain reduction using KYs to decrease the risk of development of varus deformity. This is the classical x-rays you get in the casualty setting. An anxious patient, anxious parents, you can't get a true AP and a true lateral view. This is what you have, and this is what the best you can get. The patient comes late at night, and the amount of swelling in his arm and elbow is like this. And you don't have the expertise for somebody to pin it during the night. What will you do? You will have to really realign these fragments together in an attempt to take off the pressure from the brachial artery and the median nerve. Don't leave this fracture as such displaced until the morning. You have to realign it during the night, put it in a slab until expert hands come in the morning to do it under C-arm control. So next morning, this fracture should be pinned under C-arm control. And there are some sort of behaviors in the operating room which have been inherited from generation to generation, which I don't recommend you to do. Don't use your image intensifier as a fracture table. Don't use it to put the hand on, the elbow on, because it's been published in several papers internationally, and it's happened in Alexandria, where the surgeon went with the K-wire through the C-arm, causing electric shock to the patient, to himself, and ruining the C-arm. Use a hand table, and the C-arm comes under it. Don't use your image intensifier as your operating table. The other thing, prior to pinning, you should achieve anatomical reduction. Anatomical reduction is the key to successful pinning after that. If you can't get your fracture reduced closed, you will have to do an open reduction. And you can do it by several approaches. The steps of reduction are, first of all, the patient is given a general anesthetic and a muscle relaxant, And as he's lying on the table, as you've just seen him, you are going to apply traction to the forearm with counter traction on the arm or at the axilla. So traction here and counter traction above. And you give this a few minutes until you feel a thud. You feel the distal fragment coming close to the proximal fragment. They're usually displaced like this. And it comes gradually where they line in a position. And then you start adjusting the varus valgus malalignment, the coronal malalignment. And then you correct the rotation. And then lastly, you start forward pushing the distal fragment while flexing the elbow into a hyperflexed position. Forward push of the distal fragment with hyperflexion of the elbow. Of course, when you are getting an image intensifier picture for a lateral view, this is easy. But with it being hyperflexed, you can't get an AP. To get an AP, you will have to extend the elbow, and you will lose your reduction. So what you do is that you keep it hyperflexed as such. You get that Jones view. And in that Jones view, you can see the radius and the ulna here, superimposed over the distal humerus. This is the distal humerus, and you can see clearly that this area has been well aligned. So don't forget that Jones view. With the elbow hyperflexed, you get an AP of the distal humerus. Don't extend the elbow. And then when you do this, you get the lateral view on the CR. And this is after pinning. And sometimes when there's a lot of swelling on the medial side, you don't know where the ulnar nerve lies. So the best thing is to do 3 lateral K-wires, not 2, and not 2 parallel, and not 2 convergent. The 3 gives better stability than 2, and don't use 2 lateral pins. They don't give rotational stability. And this is the post-op X-ray. In case 2, this is a child with a supracondylar humerus and an extension down into the distal humerus, not reaching the articular surface. It was reduced and put in a cast, and after 2 weeks, you can see that it is drifting into varus. There's varus malalignment, but there's callus formation posteriorly. I was hesitant. Do something, don't do anything, just leave it to heal, and then varus alignment, malalignment, varus deformity, do an osteotomy later on. I opted to go ahead and try to push it into a straight position and K-wire it, pin it. So you can see the difference between the varus here and the straight radius, humerus, in that view. Okay? Don't accept reductions like these. This malreduction, malrotation, and this distal fragment is still posteriorly displaced with a spike impinging in the proximal radius, with callus formation around here. At this stage, 3 weeks down the line, you can't do anything. It's well united. And you can't derotate it. Maybe you can adjust varus valgus. You can never derotate it 2 weeks. It's already hindered by callus, held by callus. Case number 3, an 8-year-old boy after closed reduction, again, unacceptable reduction, as you can see here, malrotation there. What are your thoughts about this? This is a hand which is well perfused, but it's pulseless. And we see these, you see these a lot. You reduce the fracture, you put it in a slab, and you put your hand over the radial pulse, you can't feel it. Call the vascular surgeons. The vascular surgeons go and request angiographies and Doppler ultrasounds. And then at the end of the day, the collateral circulation takes over, and this hand or this limb survives. Sometimes we make a fuss about this pulseless hand, but so long as it is well perfused, don't make a fuss about it, because this is what was done. I'm asking you, how would you treat this? What's your next step? Any thoughts? حد يقول لي تحبوا تعملوا ايه للكسر ده؟ زي ما هو كده day 1. سيبه كده، نعمل له حاجة، نعمل حاجة ثانية. ايه رأيك؟ ايه رأيك دكتور؟ Leave it like this? Huh? Not accept it. So you would attempt another reduction. You would revise this reduction. Okay. So that your colleague here would like to revise this reduction. The vascular surgeons asked for Doppler sonogram and arteriogram, which was performed. And then you can see in the angiogram here that there's blockage of the blood flow down the brachial artery at the level of the fracture almost, and down into the forearm. But you can see that there's very good collateral circulation. فأنت تكلم الفاسكولار سيرجن خليه يجيلك for medical legal purposes طبعا, and he might go ahead and do these things. But at the end of the day, this forearm is well perfused, and the hand is perfused, and the collateral circulation is fine. And this is usually what happens in these cases. What was done is that he couldn't get it, the surgeon reduced closed, he had to do an open reduction and realign his fragments and fix, as you can see, with 3 KYs again. He's adjusted the rotation and he's adjusted the valgus malalignment. And this hand went to uneventful healing, good function of the elbow, with survival of the limb. What are the complications of these fractures? Brachial artery injury, median nerve palsy, malreduction leading to cubitus varus, necessitating later on corrective osteotomy, heterotopic ossification, seen a lot in our country. يروح للمجبراتي يقعد يحط له زيت ويدلك له وبتاع مش عارف ايه وبعدين يجي لك بالهيتيروتوبيك ossification and a stiff elbow. We see these a lot. After pinning, you can end up with an ulnar nerve palsy when you've pinned on the medial side when you don't know where the ulnar nerve is. If you want to do this with a very swollen elbow, make a nick incision on the medial epicondyle. Make sure that you're away from the ulnar nerve while putting your medial KY. The second fracture is the lateral condylar fracture. Fractures of the lateral condyle are transphyseal intra-articular. They go through the epiphyseal plate and into the joint, so they are intra-articular injuries. The second most common operative elbow injury after supracondylar humeral fractures. They sometimes are difficult to diagnose when they're like a crack and there's not much swelling on the lateral side of the elbow. You can't really see them on the X-ray. There's a propensity for late displacement. Even if you treat somebody conservatively in a cast, get him in 1, 2, and 4 weeks with X-rays, making sure it's not displaced. If it displaces and it's an intra-articular fracture, you will need to do an open reduction and fix it with wires. So make sure that your undisplaced fractures do not displace along the course of the follow-up. Factors sometimes make treatment risky, and we'll come to this when we talk about the open reduction. They are classified according to Milch and Salter and Harris, these are the widely used classifications, into a type 1, which is a fracture going into the joint lateral to the trochlear groove. And this type 1 is a Salter-Harris type 4, because it goes across the epiphysis into the joint, through the epiphyseal plate, into the epiphysis, into the joint. So this is a type 4. While a type 2 extends medially, making the elbow unstable. See where this ends, where this ends? This takes part of the elbow joint, making it unstable and presented with a subluxation of the elbow. And this type 2 is a Salter-Harris type 2. For sake of remembrance, for the exam purposes, type 1 is a 4 and type 2 is a 2. Okay? Both classifications have very little prognostic value regarding treatment and complications. Jacob, in 1975, reproduced fractures in a cadaveric study, and he looked at the presence or absence of a medial cartilage hinge, which he thought was a key diagnostic factor. The best way to identify the hinge is with a non-displaced fracture less than 2 millimeters. He called this non-displaced. Minimally displaced 2 to 4 millimeters, and displaced fractures more than 4 millimeters with complications 3 times more in type 3 than type 2. And this was found by Weiss et al. In 2009. Diagnosis can sometimes be very obvious, swelling on the lateral side of the elbow, tenderness, and a crepitus is sometimes felt, or can be frustratingly subtle. History of a valgus stress at the elbow. Symptoms, pain and diminished range of motion with isolated lateral tenderness. and radiographs, you get an AP, you get a lateral, and you get an oblique. In the oblique view, you sometimes may see the fracture. In this AP, you can see a crack, just the hairline crack. So you have to be very careful how to look at these x-rays, not to miss these fractures, because they are frequently missed. This is a patient who presented with a crack in the proximal ulna, and then 2 weeks, 3 weeks later, a completely displaced lateral condylar fracture with an element of some rotation. 3 weeks, very difficult to deal with. Okay? Non-displaced fractures, you put in an above elbow cast 4 to 6 weeks in supination to relax the extensor group of muscles. In periodic radiographs at 1, 2, and 4 weeks. Surgery is still a possibility. Explain this to the parents so that they don't get frustrated. Displaced fractures, open reduction through an anterolateral approach. When you're doing these open reductions, don't dissect posteriorly, because the blood supply is coming from posterior to anterior. You might end up causing avascular necrosis of this lateral condyle, this capitellum. So keep your dissection anterior, and this is where you want to be to see into the joint, see that the fragment has been replaced in position, and that the joint is congruent again. I know that a lot of you, and I, when I was still first training, used to look at the metaphyseal reduction. Slide into the joint, and creep into the joint, and make sure that the joint is well reduced. Reduction is judged at the apex of the articular surface, and use percutaneous KYs, so that you can, at 6 weeks, remove them in your clinic. You don't have to open up and remove them. They're coming out of the skin. But you've done an open reduction, but the wires are coming in percutaneously for easier removal. And an above elbow cast for 4 weeks. Minimally displaced fractures, less than 4 millimeter gap, controversial, conservative with a possibility of late displacement. 9 of 82 in De Vito et al.'s series showed late displacement, only 2 needed surgery. Closed reduction and percutaneous spinning, this you can do in non-displaced fractures or minimally displaced, but again, if you open up and see the articular surface, much better than doing a closed reduction, so that you see the articular surface. But we're talking about minimally displaced, less than 4 millimeters. This is a patient who presented 2 weeks after the injury, badly displaced lateral humeral condyle. This is after surgery. One KY is usually perpendicular to the fracture site, almost parallel to the joint, and another one divergent going up the humerus. 5 weeks post-op, this was the situation. Biomechanical analysis of lateral humeral condylar fractures treated by pinning by Bloom et al. In 2011. The purpose of the study was to determine optimum pin configuration and number of pins for Milch type 2 in a pediatric fracture model. 42 synthetic humeri, each fixed with KYs in one of 5 constructs. And the models were tested in extension, flexion, varus valgus, and internal and external rotation. And these were the configurations. 2 cross wires, 2 parallel, 2 divergent at an angle of 30 degrees, 2 divergent at an angle of 60 degrees, and 3 wires with divergence between these 2 at 30 degrees. So this was an extra 3rd wire inserted. The 2 divergent 60-degree pins provided statistically greater stability than the 30 in torsional loading and the parallel and in the parallel ones in valgus loading. The 3 divergent pins had statistically greater stiffness than all 2 pin constructs in all loading directions except varus. The clinical relevance is that if stability is questionable after 2 pins inserted at 60 degrees with maximum divergence, addition of a 3rd divergent pin enhances stability. The complications of lateral humeral condylar fractures are lateral spur formation, incubitus varus. You can see that the width of this humerus after fixation and some bone formation here is wider than the normal side. And this is what gives these patients some impression that this thing is prominent here. My elbow is broader. Delayed union, non-union with no healing at 3 months. Painful non-unions should be treated by osteosynthesis. And you will be surprised that you see non-unions in these fractures with a full range of motion. SubhanAllah. Cubitus valgus, like in this girl, you treat by corrective osteotomy, plus or minus fixing the non-united fragment. You can leave the non-united fragment unfixed because the range of motion is marvelous. Sometimes if you fix them, they become stiff and they're not happy. They've got a cosmetic appearance which looks good, but they don't have a function which they had before your surgery. Cubitus valgus plus tardy ulnar nerve palsy, ulnar nerve transposition, with or without doing an osteotomy. A fishtail deformity and AVN, again we said AVN is when you dissect the fragment posteriorly. Leave the posterior part of the fragment undissected so that you preserve the blood supply. The third fracture we're going to be talking about is the medial epicondylar fractures. 50% are associated with elbow dislocations. They occur between 7 and 15 years of age. They account for 10% of all elbow injuries. Ossification center appears between 5 and 7 years of age and unites with the diaphysis between 18 and 20. So if you get a patient with such fracture below the age of 5, it will be very, very difficult to diagnose because the medial epicondylar has not ossified yet. It gives origin to the common flexor tendon and the medial collateral ligament, and of course it is very close to the ulnar nerve lying posterior to it. The mechanism of injury is one of valgus stress, where the fragment could be incarcerated in the joint when it is associated with an elbow dislocation. You've got an elbow dislocation, an avulsed medial epicondyle, you reduce the elbow and the fragment becomes incarcerated in the joint. Classification, there's no widely accepted one. Displaced, non-displaced, no agreement on criteria of displacement. Some authors have said more than 5 millimeters is a displaced fracture. The diagnosis is made by pain and tenderness increased by valgus stress, plus or minus ulnar paresis or dysthesia. Radiographs, difficulty in diagnosing the fracture if the fragment is not united yet before the age of 5. Comparison films could be useful. Get an X-ray of the other side. The fragment, if entrapped into the joint, you will see that there's medial joint widening on the AP, that a fragment seen on the lateral view, you can see a fragment on the lateral view in the joint with non-concentric ulno-humeral joint reduction. If it's undisplaced or minimally displaced with less than 5 millimeters, you do a long arm cast. Intra-articular fractures, you do one trial of manipulative reduction. You put the elbow in flexion, you apply a valgus stress, supination of the forearm, wrist and finger dorsiflexion in an attempt to pull on the common flexor origin, to pull it out of the joint. If this fails, you go for open reduction. Displaced fractures more than 5 millimeters, you apply a long arm cast, you do an ORF, you do an epicondylectomy. Well, you've not told us what to do. You can either do this or that or that. There was a study done by Farsetti et al. In 2001, long-term results of treatment of fractures of the medial epicondyle, humeral epicondyle in children. 42 patients who were treated by long arm cast, ORF, and epicondylectomy. And they came to the conclusion that non-surgical treatment with 5 to 15 millimeter displacement yielded good long-term results similar to those obtained by ORF. So even if you treat it conservatively with a displacement as such, it will still have the good end result as doing an ORF. Non-union did not adversely affect functional results. If it doesn't unite with a long arm cast, it doesn't hinder the function. Epicondylectomy should be avoided because of poor long-term results. So either go for a cast or ORF, and the difference is not that great. And in these two groups, the conservative and the ORF, they had almost a 19 and a 17 patient population. Thank you very much.